46XX DSD, also known as 46XX testicular disorder of sex development or XX male syndrome, is a rare condition where an individual with a typical female chromosomal pattern, that means 46XX, develops male external genitalia. Disorder or difference in sex development or DSD in patients with 46XX karyotype occur by prenatally or postnatal exposure to an increased amount of androgens. These disorders are usually diagnosed either at birth in newborn with abnormal genitalia or later, usually at puberty, due to postnatal viralization. The prenatal source of excess androgen in 46XX patients are either of fetal origin, which can be gonadal or adrenal, either also placental or maternal. It can be from fetal, placental, or maternal. When we came to sign the symptoms of 46XX DSD, the most common symptom is ambiguous genitalia. External genitalia may appear male, female, or a combination of both. Individuals may have testicles, sometimes with ovotestes, that means containing both ovarian and testicular tissue. In addition, development of male secondary sex characteristics can occur, such as deeper voice, facial and body hair, and a larger muscle mass. Breast development in males can occur due to hormonal imbalance also. Males with 46XX DSD often experience infertility due to azoospermia or absence of sperm. Individuals may have a uterus and the fallopian tubes, which is female, or combination of both male and the female internal structure. Possible signs include inguinal hernias, cryptorchidism, and in some cases, signs of masculinization or even cyclic hematuria, in addition to what I've said above. 46XX DSD can be caused by a variety of factors, including genetic mutations, hormonal imbalance, and sometimes even unknown causes. But the most common cause is congenital adrenal hyperplasia due to 21-hydroxylase deficiency. So, congenital adrenal hyperplasia due to 21-hydroxylase deficiency is responsible for 90 to 95% of 46XX DSD. Congenital adrenal hyperplasia is a group of genetic disorders that affect the adrenal glands' ability to produce certain hormones, including cortisol and aldosterone. Particularly those caused by 21-hydroxylase deficiency, there is inability to produce cortisol and aldosterone. So the precursor hormones are shifted to the androgen side. This can result in ambiguous genitalia at birth or later development of female characteristics due to excess androgens, which can be produced, leading to viralization of female fetus. Key lab findings include elevated levels of 70-hydroxyprogesterone and adrenal androgens with decreased cortisol level. In addition, STH stimulation test or genetic testing might be needed in certain cases to confirm diagnosis. Treatment of 21-hydroxylase deficiency involves hormone replacement therapy to address deficiency and manage symptoms. Glucocorticoids like hydrocortisone are used to replace deficient cortisol and suppress excessive STH production. Mineralocorticoids such as fludrocortisone are given to those with the salt wasting form to manage aldosterone deficiency. In some cases, surgical reconstruction may be needed for female infants with ambiguous genitalia. The other is SRY gene translocation or sex-determining region on Y chromosome translocation, which is typically located on the Y chromosome and crucial for male sex differentiation. This can be translocated to the X chromosome during meiosis in the father. This leads to 46XX individual developing male or ambiguous genitalia. So this is known as SRY positive 46XX testicular DSD. Treatment for SRY gene translocation, which can lead to 46XX males or Swyer syndrome, focus on managing the associated symptoms and the potential complication rather than directly targeting translocation itself. So hormone therapy, surgical intervention, and psychological therapy might be needed. XX males, testosterone therapy is often used to promote male secondary sex characteristic and address hypogonadism. In Swyer syndrome, SRY negative 46XX, estrogen and progesterone replacement therapy is used to induce menstruation and develop secondary female characteristic. The third cause of 46XX DSD is excess androgen exposure. Even without genetic mutation, exposure to excess androgen during fetal development can cause 46XX DSD. This can stem from the mother due to luteoma or androgen secreting tumors such as PCOS, or the fetus itself from the adrenal gland or placenta. The fourth one is aromatase deficiency. Aromatase is an enzyme that converts androgens to estrogen. Deficiency in aromatase can lead to excess androgen and potentially 46XX DSD. This can affect both the mother and the fetus. Placental estrogen support fetal development and maternal adaptation to pregnancy, such as uterine growth, breast development, and others. Placental aromatase deficiency is a rare autosomal recessive disorder caused by mutations in the CYP19A1 leading to deficient activity of aromatase enzyme. As I have said, aromatase catalyzes the conversion of androgen to estrogen. This condition manifests with maternal viralization during pregnancy, which is accumulation of androgen in the maternal circulation due to impaired placental aromatization, and also fetal effect. Female fetus exhibit ambiguous genitalia due to androgen excess, while male fetus are typically unaffected. Postnatal presentation in affected females with viralization at birth might be evident, and delayed puberty or primary amenorrhea with low estrogen level may occur. Diagnosis involves clinical presentation, hormone analysis showing elevated androgen to estrogen ratio, and genetic confirmation. Treatment typically includes hormone replacement therapy for affected individuals and prenatal counseling for at-risk pregnancy. Aromatase deficiency treatment primarily involves estrogen replacement therapy to address the effect of the deficiency, particularly in males. This therapy helps with bone maturation, bone density, and the normalization of hormone level, including FSH and LH. In females, hormone replacement therapy can also help with breast development, menses, and other pubertal changes. The other is unknown cause. In some cases, the cause of 46XX DSD remain unknown, even with advanced genetic testing. This is a short summary of 46XX DSD. Thank you for watching.